which is on chronic migraine by Dr. L.J. Basumathi. Sir is consultant in Apollo Hospitals, Guwahati. He'll be talking about botulinum toxin protocol and injection techniques in chronic migraine.
Very good evening to all of you. And at the outset, I would like to thank Karnataka Movement Disorder Forum and Prasanna LK sir for giving me this opportunity. And I would like to thank Gufic Bioscience entire team for this opportunity. So without further ado, so I'll start. So the migraine is most common, one of the most common neurological disorder, you know. And I want to ask the resident, among the medical fraternity, which specialty has highest incidence of migraine? Anybody? Yes, neurologist. You can see in the there is a textbook called Adams. In 1995, it was written 26.7 to 48.7% incidence among neurologists. Yeah. Yeah. Yes, sir. Yes, sir. It may be, yes, it may be because those who are non-neurologists, maybe we are not diagnosing them as we are diagnosing ourselves. Yes, sir. Okay. 90%. Mm-hmm. Yeah. Mm-hmm. Okay. Yes, sir. Thank you. And I'd like to, this is my acknowledgement to my mentor. I'm so glad today my mentor is sitting in front of me, where I did my fellowship. Then Dr. Ferry, who encouraged me a lot during this process. Then other stalwart, you already know them, Dr. Jankovic, you know. So I'll be very brief in presentation. So I'll walk you through a chronic migraine overview and the risk factor. What is the risk factor for progression to chronic migraine, and what are the injection technique for botulinum toxin in chronic migraine? So, as you know, it is one of the most common, very complex and interesting neurological disorders. It is not just only headache. There are so many things. There are so many spectrum in migraine. So it affects 1 in 7 individual, and it is more common in women than men. And it is now known that it is not a functional disorder. And you can diagnose migraine by a formula called 5-4-3-2-1. So you need to have 5 attacks. And the duration of headache should last from 4 hours to 3 days. That is 5-4. Then out of 4, you need 2, like unilateral pulsating headache, severe headache that impair activities, or it brings, and then the photophobia, phonophobia, and 1 out of nausea, vomiting, and photophobia, phonophobia. So 5-4-3-1, very simple. So this is one of the top 10 most disabling medical illness on earth. So as you know, it goes through 5 phases. First is prodrome, followed by aura, which happens in 30% of the patient. And that is ictal phase is called headache, then followed by prodrome and interictal phase. So there is huge overlap between these 5 phases. Most of the time it is a continuum. For example, if you see the prodromal phase, it is characterized by activation of the hypothalamus, posterior hypothalamus, which is a basic homeostatic, it maintains the basic homeostasis in the body. So there is a fatigue, then food craving, then the sleep-wake cycle disorder. So there's so many things. And photophobia, phonophobia. According to expert, these phases, it happens all throughout the 5 phases in the migraine, but it is overshadowed by the most severe headache. The headache phase overshadows all the other features. So that is one thing that has come up in recent time. Then this prodrome, already mentioned, it is due to activation of posterior hypothalamus. Then aura, the aura phase, you know, it's because of cortical spreading depression, which spread from the posterior to anteriorly at a speed of 2 to 6 millimeter per minute. And its aura, most common aura is visual aura, followed by sensory or somatosensory aura or speech aura. There are so many things. Then it inhibited cortical activity and it reduces blood flow, and which leads to this is intracranial. This is very interesting. This is intracranial activation of peripheral trigeminal sensory nerve fiber that causes input, that gives input to the trigeminal ganglion. So this is intracranial activation. And the headache phase, you already know that this headache phase also characterized by sensitization, which is two types. One is central sensitization, one is peripheral sensitization. And this the peripheral component I have already mentioned. The central component, after trigeminal nucleus, the input goes into trigeminal complex. Then it sends the signal to trigeminothalamic tract to the thalamus. From thalamus, the signals goes to the third order neuron, to the sensory cortex S1, S2, and also to the posterior cortex. So this is how headache occurs. Then the principal biochemical mediator in headache is there are many biochemical mediators. One of the most commonly recognized, recently recognized, is CGRP. That is calcitonin family, which is a 37 amino acid neuropeptide, and other like PCAP and others neuropeptide like nitric oxide, then the neurotransmitter like GABA, serotonin, etc. And this CGRP is the hot topic in the migraine, because the new molecules which are coming up is that either they are CGRP receptor blocker or it is a direct CGRP antagonist. So they causes myriad of symptoms like nociceptive activation, peripherally vasodilation, and aseptic inflammation in the meninges. And they are also responsible for corticospasmic depression and the main trigeminal sensory activation and central sensitization. Then postdrome phase is almost same as the predrome, and this is interictal phase. It is also found by the PET study, 15H2O PET study, that the certain areas of the brain still remain active in migraine than the normal individual. Those areas are actually posterior cingulate, lingual, and visual cortex. So now coming to the topic proper, this is a chronic migraine. It is believed that 150 million people in the world suffers from chronic migraine. And if you see the spectrum, episodic migraine can be low frequency episodic migraine to high frequency episodic migraine, followed by a chronic migraine. So chronic migraine by definition means you need to have 15 headache days per month, and out of these 15 headache days, 8 should have a migrainous character, or these 8 headaches should be aborted by triptan or migraine specific medication. So 15 headache and out of 8 should be migrainous type for 3 consecutive months. So there is also a debate that whether this threshold 15 is more important than the rising frequency of migraine is more important for a preventive strategy. For example, suppose I am having 4 headache attack, 4 attack every month, then my next month I am having 8 attack, but I am not approaching 15. Next month I am having 12. So that is more important than having a fixed cutoff of 15. That is what expert says and the newer literature. So the chronic migraine is a spectrum of chronic daily headache. You already know that there are 4 types of chronic daily headache. I'm not going into detail. So what are the key risk factors for migraine disease progression from episodic to chronic migraine? So mainly 5 domains are there. Number 1 is innate migraine characteristics, then suboptimal treatment of the migraine, and associated comorbidities like anxiety, depression, and obesity, then lifestyle and exogenous factor, then other demographic factors. So these are the most statistically significant risk factor for migraine disease progression. More than 5 migraine headache days in a month, or more than 10 headache is the highest risk. For example, then another study has found that cutaneous allodynia is another risk factor for progression into chronic migraine. So what are the preventive therapy for chronic migraine? So when do you want to use preventive therapy? It depends on many factors. Number 1 is acute medication overuse, and if patient has a preference, then I'm disabled with the headache, even if it is 15 or 14, I need to have a preventive strategy. And a very frequent headache, more than one headache episode per week, or there are certain migraine headache where you need to use the prophylaxis. Like if the migraine with it's a migraine with the aura, the migraine with complication, retinal migraine, the hemiplegic migraine, you have to use prophylaxis in those migraine. So based on these PREEM studies, actually this botulinum toxin was approved in migraine in 2010. So PREEM study, briefly I'll be citing here. The PREEM study has two phases. One is double blind phase, and one is, next phase is the open label phase. So double blind phase, it was started with 2 doses of botulinum toxin at 0 and 12 week. You can see here, at the end of 24 weeks assessment, when it was a double blind, you can see the headache days from the baseline. Mean baseline was 20 days for in both placebo and botulinum toxin group, and it came down to 8.7 days in treated group and placebo at around 7 days. So which was statistically significant. And there was they have also assessed many secondary efficacy variable like headache severity, migraine days. Everywhere they have found significant difference between the botulinum toxin injection and the placebo. So now coming to the final part, what are the injection techniques for chronic migraine? So we, as a whole, worldwide, people advocate PREEM paradigm. PREEM paradigm is based on two principles. One is fixed site and fixed dose paradigm, and one is follow the pain. And then this is a new technique they have tested in a single open label study. They have tried to follow the sutures, because the sensory nerve, which end in the meninges, they come out to the scalp through emissary vein foramen or to the sutures. So they try to reduce the dose, plus they try to target the specific sensory neuron around the sutures. So it's a very interesting article. You can go through this article. They have reduced the dose to 90 unit and 18 injection in these are the site around the sutures they actually tried. This is and in the PREEM injection paradigm, so there are seven locations where you have to give in 31 fixed site. So 31 fixed site and 8 additional site that is follow the pain pathway. So there will be 155 unit in 31 site, 5 unit in each site, and additional 40 unit for another 8 site. So if you can see here, there are 7 sites. The front, that is corrugator, procerus, then frontalis. Then on the side, that is temporalis, and the back, occipitalis, and cervicus, paraspinous, and trapezius. So before you start injecting the patient, so you can inject the patient in sitting position. Means on all region you can inject the patient in a sitting position. But if the patient is not comfortable, you can ask the patient in the supine position for corrugator, procerus, frontalis, and temporalis muscle. And preferably use 30 gauge needle, 0.5 inch, and each 0.1 ml will contain 5 units of botulinum toxin. And dilution is in 100 unit, you use 2 ml. So anterior side, before going into this other side, so anterior side you have 3 muscle mainly, 2 corrugator and one the midline muscle, procerus, and the frontalis. So corrugator muscle lies just above the eyebrow, and it lowers the brow. When you frown, it lowers the brow, and you have to inject the corrugator in 90-degree angle and 5 units in each. Every point you need to inject only 5 units. Then procerus, there is a triangular muscle just above the bridge of the nose, and it lowers the brow, and here also you have to angle at 90 degree. And the frontalis muscle, it raises the eyebrow, it raises the brow, so you have to use 45-degree angle here and preferably upward. And this you have to avoid the lower part of the frontalis muscle. Okay. So precautions. So there can be different type of ptosis depending on where are you injecting. If you are injecting too low, you will have full brow ptosis. If you are injecting in the lower part of the frontalis muscle, you have full brow ptosis, and you can have a lid ptosis, and you can have reverse Babinski sign, that is called medial brow ptosis. If you paralyze too much in the medial part of the eye, like corrugator. And there can be pseudotosis. So before injecting, you have to examine for the ptosis. For example, elderly patient may have a redundant skin that is called pseudotosis. So you have to evaluate before injecting, because patient will later come on and complain that I am having drooping of eyelid. So we don't want this Mr. Spook appearance. So for corrugator, this is the way you have to hold the corrugator in between your thumb and index finger. And it is just located 1.5, 1 finger blade above the medial superior edge of the orbital ridge. And you have to pinch the muscle, then inject at the 90-degree angle, like this. So here you can use muscle pop technique to avoid hitting the periosteum. Muscle pop technique is when you hit the muscle slightly, suddenly you'll feel the resistance. So when you feel the resistance, you have to inject there. You have to avoid the periosteum in the front of the face. Then the procerus, again you have to hold the procerus muscle with your thumb and index finger, and you have to one injection. We have to inject in the 90-degree angle. And the frontalis muscle, I have already mentioned that there are 4 sites here. The first site is here. So it is just vertically above the corrugator injection, where you inject the corrugator. It is just vertically above. And the second site is the outer part of the cornea. The outer part of the cornea, where you draw a vertical line parallel to the first line. This is the second part. So these two are for the frontalis muscle. You have to avoid the lower part as to avoid the brow ptosis. And coming to the lateral side, so here also in the lateral side, when you inject there, because of excessive venous plexus, you will have a bleeding. It's prone to bleed, so don't get scared of the bleeding in the lateral part. And it is not arterial, because artery is very thick. You cannot when you prick the artery, you will come to know. It's very impossible to prick, because the temporal muscle, it's covered with the thick fascia. It's difficult. And these are the site for the temporalis muscle. So you have this line, tragus line, and the mid helix line. So just one finger blade above that, above the helix, you inject, then just vertical to that in the tragus line. And in between these 2 points in the anterior side, you have to avoid you should not avoid in front of the hairline. And because there could be some atrophy, so this could be disfiguring to the patient. So posterior side, this is very important, the neck pain. So avoid the lower neck, injecting the lower neck. I consider injecting occipitalis and spinalis within the hairline here also. And you have to keep all injections superficial in the posterior side. And the ideal guide is 0.5-inch needle serve as a depth of the guide. And this is the occipitalis here, 3 point at 45-degree angle, and cervicus paraspinalis. The first point is there. The occipital protuberance and mastoid, and in between these two, you inject here, and this is at the 2 o'clock position. Then trapezius, the inflection line or necklace line, and the acromioclavicular, the midway between this first point. Then second point is the midway between the inflection line and the first point. The third point is between acromioclavicular and the first point. So avoid using the lateral part of the shoulder and the vertical part of the neck. So this is follow the pain. If the patient complains of excessive pain, so you can use the follow the pain muscle areas here. So just for, this is how inject in the temporalis. Okay, yeah. So the main, because it is now established that the botulinum toxin is efficacious in preventing chronic migraine, but the main problem is the cost and access to the trained provider. And always use the pre-aim paradigm, which is used universally, and take precaution. That thing I have mentioned in the front face and the lateral and the back. So, thank you for your attention. Thank you.